Hi, my name is Ashley Santor. I'm one of the students here at Regis College in the Nurse Practitioner Program for Pediatrics. I am here to present the Week 10 discussion for the major depression disorder in an 18-year-old female. First-line treatment would be, for Sarah, a selective serotonin reuptake inhibitor, also known as an SSRI. The drug that I chose was fluoxetine, known as Prozac, and it is used to treat major depression disorder. The mechanism of action for fluoxetine and other SSRIs work by blocking the reuptake of serotonin into the presynaptic neurons. This increases the amount of serotonin available in the synaptic cleft, allowing greater stimulation of the postsynaptic serotonin receptors. By increasing the serotonin activity in the brain, fluoxetine helps improve the mood and decreases symptom of depression, which is ultimately what we're trying to do for Sarah. For the pharmacokinetics, the absorption, the peak plasma concentration of fluoxetines are attained after 6 to 8 hours. Fluoxetine is well absorbed with a bioavailability of 70 to 90%. It can be taken with or without food. For distribution, it's a highly protein-bound, widely distributed throughout the body, and crosses the blood-brain barrier to act on the central serotonin pathways. Metabolism, fluoxetine's active metabolite is neurofluoxetine, produced when the cytochrome P450 enzyme acts on it. The half-life is 2 to 4 days. The neurofluoxetine half-life is 7 to 9 days. Elimination, fluoxetine is primarily metabolized into inactive metabolites, which are eliminated through the urine. Only a small amount of the fluoxetine and its active metabolite, neurofluoxetine, are excreted unchanged by the kidneys. For the pharmacodynamics, increased serotonin availability enhances the serotonergic neurotransmission, helping improve mood and reduce symptoms of depression. Clinical improvement can typically be seen in 2 to 4 weeks. Full therapeutic effect often occurs 6 to 8, which is why we recommend continuing the medication even if we don't see immediate results, because we really want to reach that full therapeutic window. Second line treatment, this would be if the SSRI isn't working or there's some other contraindications. And for Sarah, this would be a serotonin norepinephrine reuptake inhibitor, an SNRI. I chose the venlafaxine. It's also known as Effexor. There's an extended release, and this can be used to treat major depression disorder. The mechanism of action is to block the reuptake of serotonin and norepinephrine, increasing the availability in the synaptic cleft, similar to how an SSRI works, just blocking different mechanisms. The pharmacokinetics, for the absorption, the peak plasma concentrations are typically attained within 5.5 to 9 hours for the extended release, which is what we're focusing on for Sarah. It's well absorbed orally and has a lower bioavailability of 45%, and it should be taken with food. Distribution, this is a highly protein-bound, widely distributed throughout the body, and crosses the blood-brain barrier to act on the central serotonin pathways. Metabolism, it's primarily metabolized by the liver, predominantly through the cytochrome P450 system, particularly the CYP2D6 enzyme. Elimination, most of the venlafaxine is eliminated through the urine. For the pharmacodynamics, this increases serotonin and norepinephrine concentrates in the synaptic cleft, enhancing the neurotransmissions and improving the mood. For the prescription for fluoxetine, I decided to write 2 scripts for Sarah. This is something that you could discuss in person with the patient to decide what they felt would be the easiest to follow, to make sure that there was no misunderstanding or complications in taking the medication. So for my first prescription, it would be for fluoxetine 10 milligrams to take one capsule by mouth once a day in the morning for 7 days. It can be taken with or without food. Then, after those 7 days, the second script would be a 20 milligram capsule. Beginning on day 8, take one capsule of 20 milligrams by mouth daily in the morning. You could also write this where you could just prescribe the 10 milligram capsules and in the signature write that on day 8, we're going to take two to get 20 milligrams. So that could be decided with the patient and family to see what's best for them. This, I felt like, just made it a little bit more clear. For drug interactions and adverse effects, the fluoxetine inhibits the CYP2D6, an enzyme responsible for metabolizing drugs like TCAs, antipsychotics, antiarrhythmics, and increases serum concentrations of the drugs. There is a very long list that is available in the resources provided at the end of the packet that I would give to each patient that would say exactly which drugs would have an interaction. And we would also review if Sarah was taking any other medications in office. We would advise her to avoid alcohol, avoid St. John's wort, and then advise that some adverse effects include insomnia. This is why we are suggesting to take it in the morning, because that way we're not taking it at night and the insomnia is really kicking in. Nausea, diarrhea, anorexia, dry mouth, headache, drowsiness, anxiety, nervousness, yawning, bruising, seizures, bleeding, which isn't as common, hyperhidrosis, and then some sexual dysfunctions, weight gain or loss, muscle weakness, tremors, sore throats. There can be quite a few side effects. What we would say is if you are noticing any adverse effects, contact the provider. We can discuss whether these are mild and they may resolve, or if we need to look into switching the medications. For monitoring depressive symptoms and to treat, we want to know how the treatment's working. We can do this with screenings at PHQ-9. We can do this by talk therapy, having open communication in the office, as well as if you're seeing a therapist or a psychologist. Assessing for suicidal thoughts and ideations or behavioral changes, especially during the first 1 to 2 months after dose adjustments. We want to monitor sleep, appetite, weight, and medication adherence. It's very important to continue taking the medication as prescribed. We want to assess for serotonin syndrome and akathisia. We want to check serum sodium, liver and renal functions, blood glucose if you're diabetic, and possibly an ECG only when clinically indicated or risk factors are present. I know that the office I currently work in, before prescribing any SSRIs, we do an EKG just as a precaution. For a non-pharmacological treatments, there are many different types of therapy. There's cognitive behavioral therapy, there's combining therapies with your SSRI and CBT. There's interpersonal psychotherapy, problem-solving therapy, behavioral activation therapy, short-term dynamic psychotherapy, and then it's lifestyle modifications. It can be also recommended regular exercise, sleep hygiene, make sure we're getting enough sleep, going to sleep around the same times, making sure that the fluoxetine isn't causing any insomnia, having good nutrition, balanced meals, making sure we're not skipping meals, especially in the morning. There are alternatives, which would be electroconvulsive therapy, or there is repetitive transcranial magnetic stimulation. So these are all options that can be discussed in office to see if it is something that would align for Sarah's needs. For education, taking fluoxetine as prescribed once daily in the morning, with or without food, is very important. We always want to take the medication exactly as it's prescribed, especially with an SSRI. And we want to continue taking it, even if we don't see immediate improvement. It can take 4 to 6 weeks to really notice that therapeutic effect. Notify the office if symptoms of serotonin syndrome occur: fever, confusion, muscle rigidity, tremor, diarrhea, Really, if you feel like anything seems wrong or abnormal, then we want you to call and discuss it. We'd rather take the phone call, have the time to understand how you're feeling and if this is working for you. A black box warning is increased risk of suicidal thoughts and behaviors in children, adolescents, and young adults. Closely monitor for worsening depression, behavioral changes, and suicide ideations, especially during treatment initiation and when changing dosage. We want to avoid alcohol. Do not operate any heavy machinery until we know how your body reacts to this drug. And I want you to contact the office with any adverse effects. Please review the handout that's provided. There's always a pamphlet provided at the end from our office with all the information. If there's something that's not in there or something that you would like further detail on, please call. We have a 24-hour answering service with our nurses, and they will always send the message to the provider if needed. Then we have our references, and that is all for today. I hope you enjoyed the presentation. If you have any questions, please feel free to email me. Thank you.